Welcome everybody to today's webinar on reducing surgical site infections with evidence from global surgical research. My name is Dr. Antonio Ramos and I'm Professor of Surgery and the Hub Director for the Global Surgery Unit in Mexico. Today's webinar will consist of quick presentations and breakout sessions as well as panel discussions. So I will like to introduce our chair and key contributors. So let me please introduce Professor Dion Morton. Professor Morton, he's Professor of Surgery and Co-Director of the NIHR Global Surgery Unit and will be our presiding chair.
Good morning, Antonio.
And I'd like to thank you for joining us today. I will also like to present Professor Stephen Tabiri. He's Professor of Surgery and Co-Director of the NIHR Global Surgery Unit, and he's based in Ghana. Stephen. Professor Soji Ademujiwa, he's Professor of Surgery based at the University of Lagos in Nigeria. Following that, I will present Dr. Anil Vangu. He's a consultant surgeon, senior lecturer at the University of Birmingham in the United Kingdom. And in addition, he was the principal investigator for the CHEETAH study that we'll be discussing today. Anil. So welcome everybody, and thank you all for joining us. Soji, please, could you start with the introduction to surgical site infections?
Morning, good afternoon, good evening from any part of the world that you are hearing us. It's a pleasure to be on this very special edition of the Surgical Site Infection webinar organized by the National Institute of Health Research, the Global Health Research Unit, anchored at the University of Birmingham, the United Kingdom. Soji Ademujiwa from Nigeria. And I'll be discussing a little bit about surgical site infection, the definition, why it is important, and what NIHR has contributed to the topic. Infection is defined as the presence and persistence, otherwise known as contamination, of microbes, as well as the proliferation, which is colonization of microbes in a particular tissue. Microbiologists say that the count should be 10 raised to power 5 per gram of tissue. And this is usually associated with clinical signs and symptoms, such as swelling, redness, pain, loss of function, as well as tenderness. Surgical site infection is quite important to the patient, to the surgeon, and to the management. It's important to the patient because it leads to pain, and pain is a very, very major issue, major concern of any patient. Secondly, because of egress of pus, usually there is odor, which the patient is not happy with. Also, because of the surgical site infection, many a times the scars are not cosmetically acceptable. So the patient is not very happy with the scar. In addition, it leads to prolonged hospital stay. So the length of hospital stay is prolonged. And this definitely will impact, particularly in low and middle income countries, where health care costs and expenditure are covered as out-of-pocket expenditure. It has a lot of economic costs to the patient. To the surgeon, it's a lot of concern. First, the primary aim of the surgeon is for the patient to be satisfied. So the fact that the patient is not happy also impacts on the psyche of the patient, of the surgeon. Secondly, the fact that the patient stays long in hospital will impact on the time the surgeon could have used for other patients being spent on this patient. And then, of course, the length of hospital stay is also very important to surgeon when it comes to management of beds and availability of beds for other patients who may require it. Lastly, the management is very, very interested in surgical site infection because it affects management of beds, availability of beds, as well as the fact that the length of hospital stay could also increase the costs of consumables and man hours that are used by management to manage a single patient that could be used for others. Lastly, I will talk about why we think surgical site infection is very important and what we have done so far. So we looked at mortality, and we discovered that surgical site infection is the commonest cause of morbidity. And in Global Search 2, we saw that the surgical site infection rate in low and middle income countries is 2 to 3 times that of high income countries. And that then led us to the first randomized control trial, the Falcon study, which looked at recommendations by the WHO, which were tested in a very robust RCT, and showed that those recommendations did not impact the surgical site infection rates. And I think on that, we are going to soon have a poll to find out what the practice is among the audience. I think I will stop here so that we can discuss other things.
Ademuyiwa, I think we are getting really interesting results.
Yeah, that's quite interesting. The aim of the poll is to find out whether the publication of Falcon has changed practice, particularly in low and middle income countries where the alternatives are quite expensive. And I think from what we can see, for majority, about 71%, the practice has remained the same. I hope it will be interesting to see what the poll will be after the Cheetah presentation. Thank you very much. Antonio.
No, thank you, Soji. I think those were interesting results from the poll, and I thank you for your comments. So I would like now to introduce Dr. Anil Bangu. He's consultant surgeon and senior lecturer at the University of Birmingham, UK. And as I was mentioned before, in addition to that, he's the principal investigator for the Cheetah study that we are discussing today.
Hello, my name's Anil Bangu, and I'm a clinician scientist in surgery and a consultant surgeon at the University of Birmingham. I'm also one of the investigators of the Cheetah trial, and it's a pleasure to be talking to you today. Cheetah was our cluster randomized trial of sterile glove and instrument change before closing a wound to reduce surgical site infection. The trial was delivered across the Global Surgery Network with the hub lead shown here, and that network covers Ghana, Benin, Mexico, Rwanda, India, Nigeria, and South Africa. These are the clinical leads who coordinate the networks and the research prioritization and delivery across their countries. Together, this forms the NIHR unit on global surgery. This is a short presentation which is going to focus on the key methods and the primary outcome. The main background is that there's no recommendation by the World Health Organization around changing gloves or instruments before wound closure after surgery due to a weak evidence base. However, it's a biologically plausible intervention. That means there's a rationale that it could work. There's a behavioral change that is necessary though, because the whole theatre team will need to change their gloves and instruments, and there's a cost implication. So before just doing it, better evidence is needed to guide behavioral change and to guide policy. This is a PICO summary of the trial. The trial included adults and children undergoing abdominal surgery with an abdominal incision of greater or equal to 5 centimeters and a prediction of a clean, contaminated or dirty surgery finding. Caesarean sections were excluded because in some of these settings, consecutive patients that include caesarean section will mean that over 95% of the trial it would include those operations, but we wanted this to be relevant to a very broad range of abdominal operation types. The intervention is a change of glove and instruments prior to wound closure for the whole scrub team. So that's prior to closing the fascial wound. The whole scrub team changes their gloves and new, clean, sterile instruments are used. And we provided training to teams in how to achieve this, including the role of double gloving. And the comparison was routine practice, whatever the surgical team would normally do. The outcome was surgical site infection at 30 days after surgery, defined by the CDC criteria. Now, our theory was that once you've trained a team, that team likes to continue doing what they've learned to do. So we designed this as a cluster randomized trial. That means each hospital was randomized to either the intervention or comparison. And each hospital had a target of around 200 consecutive patients, but the consecutive part is key. So this doesn't include selected patients. This is consecutive patients to achieve as many patients as they could, up to and around 200 patients per cluster. We provided in-depth training and monitoring throughout the trial to ensure that we achieved the target of recruiting consecutive patients. In a brief summary of this trial, 81 hospitals were randomized from 7 countries, and that's 13,301 patients, which is a big surgical trial and a big achievement for the network. You can see the 2 arms here, intervention and control. So roughly half of patients were elective, about 2/3 of patients had an open midline incision, and about 1 in 5 patients underwent what we call dirty surgery, that's heavily contaminated surgery. So the full list of these demographics are shown in the main paper, but these are the highlights, and I wonder how relevant these are to your surgical practice. This is the primary outcome of the trial. So this showed a significant reduction in surgical site infection at 30 days when gloves and instruments were changed. This was minimized for the key imbalances between the 2 arms as well, because imbalances are very common in cluster randomized trials. And when we analyzed the primary outcome in different ways to take into account things like missing data, the finding remained robust. We've also performed a cost effectiveness analysis. So what this shows is that the small additional cost of gloves when applied to all patients was cost neutral compared to not supplying and paying for extra gloves. But there is a clinical effectiveness of changing gloves. In total, that means that this is a cost-effective intervention, and this is important as we go to policymakers. So to summarize, we've shown a significant and robust effect of changing gloves and instruments for the whole surgical team prior to wound closure. We didn't include cesarean sections, and we didn't differentiate between superficial and deep wound infections. But equally, we didn't want a trial that comprised mostly cesarean sections, and nor the differentiation between superficial and deep wound infections is subjective, and they will undoubtedly overlap. Our next step, the paper has been published in The Lancet, which we'll be sharing the link with you soon. So please do access it and read the full paper to really understand it in depth. We're very keen for people to undertake local presentations, and we'll be presenting them with the slides. And the next step is to globally implement Cheetah around the world. Thank you.
Professor Morton.
Thank you, Antonio. Great pleasure to be here. Great talks. Thank you from our colleagues. Professor Ademiyiwa, would you like to join us on the panel? Dr. Katie Shaw from Oxford, would you like to, from Edinburgh, would you like to join us? The Scottish flag noted. Could I also invite Professor Ghosh from Ludhiana in northern India to join us on the panel? I'm sorry that Professor Tabiri from Ghana was not well this morning. He might be joining us in a bit. But
I'm here, Dion. I've been able to
come in, Stephen. Great to hear from you. So look, we want to talk with our colleagues about the meaning of these results. And I was going to open with Katie. So Katie, Why do you think these particular results should be practice changing when changing surgical practice is so challenging? Katie.
Thanks very much, Dion. Great to see everyone here on the call today, and thank you for inviting me to join the panel. So I think there's a couple of things that I would say in response to your question, Dion. First of all, Anil has talked in his presentation about the real high quality of this study and the real strength of the evidence. It's really important as you try and move from a sort of anecdotal observation or something that you think might work to have really strong, robust evidence base. And the CHEETAH trial was done in such a way, lots of variables were controlled for, as Anil talked about, analysing compared to the imbalance in the trial. And still the finding is robust. It's really clear evidence and really strong evidence that the intervention works and makes a difference. It's been done in a really diverse population. So we've carried this out across our international network. There's thousands of patients from lots of different hospitals, lots of different types of hospitals. And it's produced really generalizable results that can be taken across different populations, almost anywhere in the world. And I think the other really important thing is the cost effectiveness study that Anil talked about in the results there. It's been demonstrated that this is a cost-effective intervention. It's a simple intervention. It can be done in almost any hospital in any setting, and it is cost-effective. And I think when you take those things into consideration, the quality of the evidence, the quality of the data, the strength of the evidence, and the cost effectiveness, it's really compelling that this is an intervention that everybody should be adapting into their surgical practice.
Katie, thank you. That's a very comprehensive answer. I'll hold it there, and I'm going to go over to Stephen Tabiri, Professor Tabiri from Northern Ghana. Stephen, you have created a national surgical network in Ghana. How easy was it to encourage people to participate, and are they interested in changing their practice?
Thank you very much, John. Yes, we have a great network of all the hospitals, including all the teaching hospitals, regional hospitals in Ghana. It's been a great network. Initially, we had some challenges in creating the network, but with the global surgery 1, 2, and 3, most young people, most young surgeons in Ghana agreed and are motivated to take part in some of this research that we have been doing in our network. Yes, 11 hospitals were involved across Ghana, and we've got several surgical teams that took part in this CHEETAH trial. And everyone, all the teams are ready to be involved in change of practice, as far as changing gloves to improve surgical outcomes and reducing surgical site infection.
Thank you, Stephen. So, I mean, you really did an incredible job in Ghana, and clearly there's a lot of enthusiasm for doing research. Dhruv, you set up a network in India, a huge network of maybe 90 hospitals now. There's a lot of enthusiasm for doing research. Do you think we're able to change practice across India, across these diverse hospitals? What are the barriers in India, do you think?
I think, well, with just regards to CHEETAH and Falcon, I think we've been able to change practice, especially in the hospital which have participated in. I think dissemination of results is something that is one of the main barriers in implementing our results, both in CHEETAH as well as in Falcon. The fact that our network now looks at low-cost intervention, so I don't think it's cost which is the barrier. It's just a question of the information getting to the right people, both surgeons as well as policymakers, hospital administrators. I see no reason why in the coming days this is something that will not be implemented across the world, not just in Blue and
So if we go from India to Nigeria, Soji, could I welcome your views from Lagos in Nigeria? What do you think the barriers are in Nigeria to implementing change in practice?
Thank you very much. I think the first one will be that people need to know that there needs to be change. So I agree with Dhruv on that point, that we need to disseminate widely the results of this trial. and encourage surgeons. So once they know, and with the quality of evidence, I believe people will change. The second thing, which we learned from our dissemination of Falcon trial results with the engagement we had with the Ministry of Health then, was the fact that the Ministry of Health is happy to receive these results and incorporate it into policy. And then through that, it becomes like a guideline. And I think that's one route we are likely to follow in Nigeria going forward, engaging the Ministry of Health, having a stakeholders meeting with these results, and then encouraging them to buy into it as a guideline so that surgeons know that this is the right thing to do to reduce surgical site infection in their patients. Thank you.
What I've heard is that high quality research, as you've produced from the network, can influence surgeons, but we have a responsibility as a surgical community to disseminate those results and also to share how we might be able to change practice across the world. I think there is one other challenge that I just want to bring Katie back on, and that is, can we sustain high quality research, Katie? What are we doing about that in the Global Surgery Unit?
I think in order to sustain high quality research, what we need is to build capacity within our network. We need to grow our network. And I think Professor Tabiri made a really good point, which is that the young people, the young surgeons in Ghana have been really enthusiastic to take on board our model of network building and harnessing the capacity within the more junior members of the team to carry out research and to contribute to our global surge type studies and COVID surge studies. And I think if we can continue to build that capacity and to offer training and education and events such as this, where we share our results and talk about how we can impact change, that will be a really strong step forward in building our capacity all around the world to sustain that really high quality research output.
So I think that that's a really vital part of it, isn't it? We need to make this sustainable. It can't just be a one-off event. I would also say that this network, the surgical network that's been created, is one of the largest research networks in the world. And I think that gives us the capability to actually change practice from the bottom up. So we need to look together as a community about how we can improve the quality, disseminate the findings, and implement change at a unit level, at a theatre level, at a hospital level, and ultimately, as Soji was saying, at a national level. Because that's really what changes practice, is hitting those different points. And I think the surgical community has demonstrated it has the power and the influence to do that. So I'm going to hand back to Antonio now in Mexico. And Antonio is going to talk to us, is going to introduce how we can maintain this quality of research that can positively influence practice. Antonio, back to you. Really like to talk to the specialists in each field now about why this aspect of research is important to delivering high quality results that can impact on change. So I'm going to open up with Risikat. Risikat has joined us from Lagos, but I'd really love it.
Okay.
Risikat, would you like to just share with us your thoughts about what is the most important aspects of health economics that can help surgeons effect change in clinical practice?
Okay, thank you, Dion. What I have to say here is that it allows different interventions to be compared, as to their benefit to the patient and their cost. And the cost not only to the patient, but also to health service. And by so doing, it helps the clinician to prioritize between different, interventions. And is also essential in explaining the need for change to managers and politicians as well, that they have a lot to do in the area of bringing about change. Thank you.
So thank you, Risikat. And that's very clear that surgeons need to understand within a limited cost framework where the cost benefits might lie, and they need to be able to explain it to their managers and to politicians. Gagandeep, we are very focused on numbers and quantitative research. We're always putting p-values. Why is qualitative research important in terms of influencing change in practice? Why should we look at qualitative research?
Dion, change is very difficult to bring about. We all resist change. So when you want to look at changing practices, I think it's very important for us to understand the perspectives and the context of the people who are going to be making that change. And this is where qualitative research is going to be very useful to develop that understanding. And then we should be able to design more effective interventions to address those barriers which people may have.
And I think we saw that highlighted in the first poll, didn't we, Gagandeep? Because actually, even high quality research doesn't always affect change, and we need to change behaviors to implement that. So I'd now like to go to Professor Kruger. Deirdre, welcome. And you've been a great supporter of the Global Surgery Unit now for many years. Deirdre, you've been trying to influence surgeons around what's important, why statistics is important. Do you struggle to make surgeons understand its importance, or do we listen to you?
I think it has been such untreaded territory for surgeons that really our aim is to bridge that gap. And again, build capacity both ways to get our statisticians to better understand surgical data analysis, and at the same time, equip the surgeon to understand, but what did their study results actually show, and how? How did we reach that conclusion? So I do think statistics is very important. And I think Cheetah is a prime example of how a really well premeditated study design does ensure a good study outcome, where we can really then rely on our statistical significance and report it in light of clinical significance.
Lovely, thank you, Deirdre, and lovely to see you again. Omar, would you like to just add to that? Why can't I just tell people the results? Why do I need to statistically analyze them to share these results?
Yes, thank you, Dion. I think there's a couple of things when it comes to statistics. One is sort of statistics aspects at the design stage. And, this was really, really important for us for Cheetah, because, if the study is not designed well, then, any analysis that you do will not make up for that misdesigned study. So for Cheetah, we had to design in a way that, we would limit bias, control for bias, and also make sure that the validity of our results when it comes to analysis stage cannot be questioned. And then at the analysis stage, we didn't just do, one analysis. Like Anil mentioned, we did several analyses. We did sensitivity analysis. Okay, what happens, if you just analyze, those who adhere to the protocol? What happened if you analyze, just the clusters that recruited the target numbers of patients? So we did all this to show that we have a robust and a clear result.
Thank you, Omar. I take your point about the two areas. I'd like to bring in Mike now. Mike, patients and the general public, how can they help us in terms of implementation of change?
Thanks, Dion. So at first glance, the implications of Cheetah might be so far removed from members of the community because it depends on the actions of the surgical team. However, if we look at SSI, surgical site infections, when we look at the big picture, we realize that it's actually a community issue. For example, what happens to patients if they get an SSI outside of the hospital and they can't get to the hospital? How do they self-manage? How do they understand the signs and symptoms? So that's where CEI comes in. That's where developing programs on patient education and relying on local knowledge, like knowledge or linking up with community health care workers. And so when we develop programs such as these, it's very important that we make sure what we do is relevant to communities. And so we consult with them, we co-create materials with them, so it benefits them the most. Thanks, Dion.
Thank you, Mike. Yes, I mean, in the end, all of this activity is for patients, isn't it? So we have to engage the patients to make sure that what we're doing is relevant to them. So Katie, welcome back. We've heard from each of your working group chairs. You've set up these working groups to build and grow our capacity to deliver high quality research. How can you help our community in this way? Is there anything you're doing online that could be helpful?
So thanks, John. What we are building now and going forward over the next few years in the Global Surgery Unit is online resources and training materials which can be accessed by anyone within our network, and they will specifically address some of these topics that we've been hearing about this morning: health economics, qualitative research, statistics and study design. And the real aim of this is to provide enough training materials and resources that we can grow local research, so that our teams across our network can begin to start producing their own high quality evidence to drive forward changes in their own patient care, as well as delivering international global research in the way that we have been doing. We hope to use our expertise to grow local research capacity so that we can strengthen evidence generation all around the world.
Could you just share to us again, where can we access this material?
So at the if you go to the Global Surgery Unit main website and go to the training and education page there, you will see links to our online resources that are already there, and we will be adding and growing to those over the coming months.
Is it so simple that even an old man like me could use it, Katie?
It has been designed so that, Dion, you can use it.
No, I doubt that, but we'll see. I'm going to hand back to Antonio now, Antonio Ramos. I think we're just going to run a second poll with our collaborators today. Back to you, Antonio. But I hope that you see that this process today is the beginning of a learning exercise where we can start to learn from each other about implementing change. Antonio, back to you.
So as you can see, so far, all of participants that have answered the poll think that this information has helped them change their surgical practice. And that's been a very interesting discussion. So we're going to go ahead and look at future directions for global surgery research into surgical site infection. So I would like to invite Professor Morton to share his thoughts on the future of global surgical research, specifically in surgical site infection and overall.
Thank you, Antonio.
Joined by Professor Dhruva Ghosh. He's the Hub Director at the NIHR Global Health Research Unit on Global Surgery in India, and he's also Professor of Pediatric Surgery. He will be joined also by Professor Ismail Lawani, Professor of Visceral Surgery at the University of Abomey Calabi in Benin. So please go ahead.
Thank you very much, Antonio. So firstly, over to Dhruv. Dhruv, we've heard about a very successful trial today, this CHEETAH trial, published in The Lancet, carried out by hundreds of surgeons around the world from 7 different countries in 3 continents. Is that enough? Should we be doing more research into surgical site infection? What are your thoughts around that?
John, that's certainly not enough. SSI, as we all know, wherever we practice, is one of the major problems that we have after surgery. And there's a huge cost to patients and also to the health of a patient and possibly to the lives of patients, which are lost unnecessarily. So there is huge space for doing more research in surgical site infections, and also to look at measures before, during and after surgery with the entire surgical team, including anesthetists, to improve patient outcomes.
Thank you. I like that idea that we need to work beyond surgery, Dhruv. It's not just anesthetists, is it? It's with theatre teams and with ward teams, because we have to improve perioperative care. So yep. Thinking about that, Ismail, have you got any ideas? Just like to bring in Professor Lawani from Benin. Ismail, would you like to just share with us your thoughts about where surgical site infection studies and research should go now?
I think that we should think of measures before, during, and after surgery. Before surgery, we could test washing and cleaning the skin and using antibiotics, for example. And during surgery, I think that we can test the use of wound protectors or chemical or saline to clean wounds. After surgery, we could consider active wound dressing, for example. So I think that there are many possibilities that we can test. We should be focused and we should try to test those possibilities very quickly. Thank you.
Well, I agree with you. I think the scale of the network means that we can actually test new innovations and new interventions very quickly together. Anil, can I just bring you in here? Anil Bangu from Birmingham. Anil, how should we best deliver this research with a view to changing practice? Do you have any views around this?
Hello, Dion. Hello, others. Yeah, so if we use Cheetah as an example, we know the publication of the paper needs to be taken forward now. So I think we need to use this as an example of how we're going to learn. By that, I can see three key things. First, maybe we all need to map out on a bit of paper the people we'd next go and speak to about this study. So in my hospital, I'd probably try and speak to the surgical lead, probably try and speak to someone from the hospital management, maybe in procurement or innovation. And then also I'd be looking to go nationally and speak to someone at the Royal College of Surgeons, for example. So I'd create a map of the people I need to speak to, number one. Number two, I think we need to have a common slide set, which is freely accessible to anyone here, so they can present it nationally. But we would like your help with that to track who you've presented it to and how many people. And then the third thing, Dion, everyone, this is a point for debate. As surgeons looking to create change around the world, we could take on a new topic every month and try and push that forward. Or we could have a topic a year, for example. And this year, we could all be focused on implementing glove change routine practice. Next year, we could identify and take forward another finalized researched output and take that forward for 2024. So that would be a very interesting place to have a debate, because I think we're the only group of patients involved in the surgical journey, of clinicians involved in the surgical journey, who are having this sort of conversation about putting research into practice.
And Neil, that was really clear, and thank you for that. So I agree with you. I think that we need to have very clear, focused direction to what we're going to do in forthcoming months and years. I also would emphasize your point that as a surgical community, we are of such a size and scale that we can positively influence associations, governments, and the like to change practice, as well as influencing surgeons directly. Professor Ghosh, in India, do you have any thoughts about how we might best disseminate our findings and implement change for future improvement in SSI?
Yes, Prof. Morton, I think there is huge appetite to improve care, and especially SSI care, patient safety. And I think the Indian government itself is very interested in doing that. I do know that the central government is looking at various methods of improving care, not just for surgical patients, but all patients. But the surgeons have also come onto the forefront of developing surgical safety guidelines, patient safety guidelines, etc. And I think Cheetah is going to figure prominently in those guidelines in the coming years. In fact, in the coming months. And we hope that will be followed in the state governments. In India, health is a state issue, and I am sure that the state governments would follow the central government. So I think involving governments is very, very important, because at the end of the day, in countries like ours, health is something that the governments will manage best.
I think that that's an important point, Drew, you finished on, that different countries will have different policies and different ways of enacting change, and the barriers will not necessarily be the same. But I would say we can all learn from each other. We're a community of surgeons, and if we work together, we can enact change faster. And I would also say that if you know that your friends in Nigeria, or your friends in India, or your friends in Benin are already enacting change and have empowered change, that can also influence your policymakers and your government. So I would really emphasize that we're stronger together. So I think that is a great point to finish on. I think we've overrun slightly. I think we've kept well to time. I think Antonio has held the whip over us very effectively. So Antonio Ramos in Mexico, thank you so much for chairing the meeting today. Most of all, I would like to thank the network for allowing these research programs to go forward. And we'd like to work with you and your colleagues in the future to increase the empowerment of surgeons to change practice to improve care for their patients. I think that we will take away from this ideas about a focused future and how we might work as a community better. We would love to take in your ideas from the audience. And I just finished by saying that we will have a follow-up webinar in a few months' time to see how change in practice is being enacted, and hopefully to learn from each other how to better apply it. So I think with that, Antonio and Stephen, we'll say goodbye to everyone and wish everyone a good day. Thank you for your time.
Goodbye. Bye-bye.
Good luck.
Thank you.
Bye-bye.